Okay, my name is Lucy. I am a chest radiologist, kind of by a circuitous route. I initially trained at Mass General and abdominal imaging there as my fourth-year fellowship, and then I ended up going to New Zealand where I learned chest radiology and did a lot of chest radiology there. And then recently came back to the States. And now I'm head of chest radiology at UMass Bay State in Western.
Mediastinum, not a bunch, but enough to where, well, I'm kind of forced to call you guys.
So that's sort of my short story. And so now
it's new. No, it's new. But his disease is like hot.
Okay,
my screen. Right. Okay. So I've got two screens up. The one on the right is from is the first CT, and then the one on the left.
All right, man, take care.
3 months later. This is a 91-year-old guy who basically had no interaction with medical care until he needed a hip replacement. At that point, he was having some shortness of breath and had this CT scan. Hold on, I'm just going to move this thing out of my way. So he had this CT scan. As you can see, immediately the main pulmonary artery is very dilated. There's this peripheral filling defect in the right pulmonary artery. I'll just put a little, I'm still getting a minute. So that's measuring kind of high, about 70. As we look at the rest of the pulmonary arteries, you know, sometimes I see this and it's always like, is that in the pulmonary artery? Is it outside the pulmonary artery? Here it looks in the pulmonary artery, but then, you know, as you come down, it looks, you know, maybe there's some pushing out a bit. And then certainly there are some little filling defects within the pulmonary artery here. So, you know, this, I guess, could be a chronic pulmonary embolism, and, you know, perhaps CTEPH, I guess, would be one thing to think about. As I keep looking through, you know, there are these really big bronchial arteries, and really the main pulmonary artery is very large, so I sort of wonder about, like, almost like an Eisenmenger's. The right ventricle wall is really thick, and of course he had an echocardiogram where they were like, the right ventricle is normal, and I was like, yeah, but that wall is really quite thick there. So I think it's pretty long-standing pulmonary hypertension. And then I put on lung windows. Oops, for some reason it's not going. Let's just do it this way. So he has, you know, a little bit of mild fibrosis. There's some ground glass opacity at the periphery, a little focus of consolidation there. But not, you know, maybe there's a little bit of mosaicism. Not really that impressive, though, I would say, if I was going to be knocking this all up to CTEPH. In any case, so this was seen and reported 3 months ago, and it's not clear that they thought it was pulmonary embolism. I think they were actually worried about tumor. They weren't really sure what it was, and then we got another CT 3 months later. So then we have this CT, and now this filling defect is quite a lot larger than it was before. If I put it back in the soft tissue windows. Sorry. Don't do that. There we go. So this is quite a lot larger. You know, there are no new filling defects distally, and he has more inflammatory changes in the lungs, a little bit more consolidation. But my main question is really, like, what do we make of it? You know, are we convinced that this is like a chronic pulmonary embolism?
Yes.
Or is this possibly one of these mural hematomas as a complication of severe pulmonary hypertension?
No, it's CTEPH. I mean, it layers up like that. It progresses if their patient's not put on anticoagulation. It's not PAH. I don't think it's PAH related thrombus. I don't. That's what I.
As in this thrombus grows.
Yeah, you get clot growing on clot, and especially you have right lower lobe out. Your right lower lobe is out now. And yeah, I mean, we see this quite frequently.
That it just gets bigger and not on anticoagulation.
Yeah, I mean, and that's, yeah, and if they go on anticoagulation, you'll be surprised how much of it still goes away, even though it's still layering chronic thrombus.
Okay, all right. Okay.
I don't know if any other guys agree, or disagree, but.
Yeah, I agree with you, Seth. I think it looks like just CTEPH type picture, but you have the most experience, so we'll defer to you anyway.
Yeah, okay, all right. Okay, that's really helpful. So let me pull up the next case. So this is a gentleman in his 80s who carries a diagnosis of Sjögren's disease. And he has this CT, this is from 5 years ago, and on the right, and then on the left is a current CT. Unfortunately, this last CT was a CTPA. There's quite a bit of motion affecting the visualization of the lung parenchyma. And he had a CT in January at an outside hospital that looks virtually identical to the current one. At that point, he was diagnosed with LIP and put on mycophenolate. And LIP is not something I've seen a lot of, really, at all. So I'm not confident in making that diagnosis. But when I look at this looks a whole lot like smoking-related lung disease to me. And I don't see, paramediastinal cysts that are, a variable size. I don't see nodules. I see, central lobular emphysema with, a little bit of that wall thickening that is, I guess, smoking-related fibrosis on path. And I guess a separate question, is, does he have early pulmonary fibrosis that we can about because he's in his 80s? There's some dilated airways down in here, I think. But no convincing honeycombing. So the pulmonologist question to me was, do I think this is LIP, and should he stay on the mycophenolate that he was put on in January?
So Lucy, from what I'm seeing, I see a few cysts that are discrete from the kind of ground glass and other stuff. There was one or two in the bases, but usually with LIP, the cysts are pretty thin wall, basal predominant, and perivascular in distribution. And you can see ground glass, like that one. Yeah, that's a good example of an LIP cyst. But these smaller little holes, I think, I agree with you in some ways, look a lot more like smoking-related stuff. And the other thing, you can see you don't have to have nodules, LIP. You can see them sometimes, and you don't even have to have cysts. But you can also see, I've seen in Sjögren's patients also with LIP, they also get what looks like NSIP fibrosis mixed in. But I think most of what you're showing, if you go up top, looks much more like smoking-related lung disease, where you get these little holes confined to areas of ground glass opacity. Yeah, and it's more upper zone predominant. There's a few cysts in there, but yeah. And I think that's collision of fibrosis and emphysema, and with the ground glass is a bunch of inflammatory cells and fibrosis. Don't you agree, Seth?
Yeah, I think this is all smoking.
David?
Yeah.
So do you favor all smoking?
Yeah, if you're going to put in a one.
Yeah, I agree.
Progression at this point. I mean, obviously, it seems a bit worse than 2015, but
yeah.
So then the pulmonologist said, so should I take them off mycophenolate?
Probably.
Yeah, that's what I thought too. So he did.
I mean, it doesn't look like LIP. It just looks like bad smoking with some probably smoking-related fibrosis, and I wouldn't.
Yeah. Okay. And then we can watch, and if he progresses, I can think about antifibrotics. Really. Okay. I think it's going to a UIP. I don't think he's going to want a biopsy or antifibrotics, to be honest. So, okay. And my last case is an interesting one. This is an entity I had not heard of and found it quite interesting. So this is a woman who is in her 60s. She previously had a lung cancer, which you can see was treated with radiation. So there's quite a lot of post-radiation change and chemotherapy. Had been, I don't know, multiple years prior. And then she had a new cancer here in her left upper lobe. And the thoracic surgeon wanted to treat it with SBRT, but the patient was quite adamant that she wanted it out. So, and she met criteria to have the surgery. So she went ahead with the surgery and did a left upper lobectomy. So this is the post left upper lobectomy chest X-ray, and this is on day 2 post-op. So on day 0, day 1, it was pretty clear. Started a little bit of opacity, but then by day 2, really near complete opacity of the right lung, and this is just the fibrosis we saw before. And it's really unilateral. Like the left lung looks quite clear. She then had a CT scan here, which is also day 2, which shows really diffuse ground glass opacity. There's a background of emphysema. There are some septal lines, not much in the way of an effusion, and then there's actually a little bit of left fluid, which we would expect post-operatively, and the surgeon said the resident poked the lung, which is what that is. So that's not something else. That's a surgical event. So unilateral pulmonary edema after surgery. I mean, I thought, you know, well, could it be infection? Could it be aspiration? Could it be oxygen toxicity? Could it be she has a fracture here, actually, in the right humerus? Could it be a fat embolism with the right side down, but actually they had waited like 3 weeks, you know, to make sure that fracture was old enough to avoid fat embolism. And the thoracic surgeon said, you know, this is really looking pretty typical for down lung syndrome. So we looked that up and found this article is an anesthesia one about unilateral pulmonary edema after surgery, and this was just an unusual one because it was after a hip arthroplasty, after when the patient was in decubitus position. So I guess the idea is that the patient, in this case would have been right side down, would have had increased pulmonary flow to the right lung during the surgery. And then as a sort of a setup for this to happen, the prior radiation and chemotherapy may have disrupted the lymphatic drainage capacity of the lung to sort of set up a pulmonary edema in the lung that received greater amount of blood flow. So this is her. Then a few days later, she's on supportive care, and the right lung has cleared in a few days. And there were no signs of infection. There were no white count, et cetera, although she was put on antibiotics, probably. Or I know at least she initially was. So I guess I was just wondering if you guys know of this entity and if you agree that this fits that picture.
Could she have aspirated in that position too? I'd like to ask that.
I'm sorry?
Could she have aspirated into that down lung?
Yeah, I talked to the surgeon about it, and she, described her her approach, and with aspiration, and she does a lot of suction as they're extubated, and that's something that is known as a potential complication, is attended to very carefully, I guess, operatively. And she said no, there was no evidence of aspiration. Also, the immediate post-op films were clear.
And when did that humeral fracture occur? I might have missed part of what you said
It was
earlier.
she said I think it was 3 weeks old at the time of surgery, and they knew about it and specifically waited that period of time, which she said.
But did they, what did they do for positioning that arm, you know, for the surgery? If that side was down, that arm, they might have manipulated that arm a lot, and they could have launched a bunch of embolic stuff by doing that.
Yeah, no, possible. Yeah, the surgeon thought no, they knew about the fracture, they waited, they, you know, they didn't re-break it. And yeah, didn't think that was it.
I think surgeons are going to explain the radiographs and the CT scans in a favorable way, so I would
yeah.
some reservations.
So you guys, so yeah, so that was my differential. You know, I discussed the differential, and I thought of fat embolism as well.
It looks more like lung injury than it does to me like you know, lung edema from just
that's what I thought too, and I was concerned about also like a high if the patient had a high FiO2 during the surgery.
Right.
So
and they were ventilating the right lung selectively too.
Exactly. Yeah. Yeah. But would a lung injury of that level be expected to clear so quickly either?
That's a reasonable point. Anyway, yeah. The patient's better.
Well, no, sadly she developed a ventilator-associated pneumonia.
Another reason for doubting hydrostatic edema is that there's not any accompanying pleural effusion, or at least very much that I can see.
Right, exactly. I mean, I thought that went against edema as well. And then also there's, you know, there's relatively normal lung, which, you know, doesn't really go with it being diffuse edema to have such really normal lung here and then these areas of really diffuse ground glass opacity.
I think the thing I'm most suspicious of is fat embolism to the downside, given that they manipulated that arm to put her into the downside and stuff like that. So it looks like, I don't know how short of breath she was either. She got, you know, the things like fat embolism will make you more short of breath than hydrostatic edema. I don't know whether
she was short of breath and dropped her oxygen sats and was intubated, you know, obviously. Yeah. But I don't know symptomatically, like on a scale, you know, of how short of breath she presented. Okay. So I thought that was just an interesting case and an entity I hadn't really heard of before, but I guess from the surgeon's point of view, it is something they see. It clears pretty quickly with supportive care, but if they have a lobectomy, they'll die because the only thing that's oxygenating is the non-down lung. And I guess potentially something you might see more of these patients who are going through screening or who are having multiple treatments, multiple cancers treated. All right, so that's me.
Thanks, Lucy. Appreciate it. All right, David, you haven't gone in a couple weeks.
Tell me when you're ready, Jeff. Or just
just do it. Control. Do you not see the thing?
Do I have to click something?
You have to usually accept control.
It wants to use accessibility features. Let's see. That's all I'm seeing.
Oh, are you on a new computer, David?
Not particularly.
Or a new operating system?
No.
All right, well, let me take it back and then I'll give it to you again. If it doesn't work, you may need to give it permission and then log back in and I can let Travis go. Let's see. Let's see, where are you? Try again.
It says it needs to use accessibility features.
Yeah, so you have to go into the settings in a Mac and it'll give it access. I bet there was an update of the client. We had this issue with a couple people in the past couple of weeks. So I'll let Travis go, and I think you just need to go into system settings in the Mac and under accessibility, and just where GoToMeeting is, just click it, and it may make you log out and log back in, but maybe not.
Okay.
All right, here you go, Travis.
Oh, of course, I'm now getting the same thing, but I can do it really quick here. Let's see if this works. Try it. I'm gonna have to restart too. I'll be right back.
I can go, Jeff, if you want. One second.
Hopefully you don't get the same issue.
Jeff,
All right. Do you see my screen?
We see your screen.
Yep. Excellent. Good old PC. None of that Mac crap. So, when I first saw the chest X-ray, I thought it would be a pretty simple diagnosis. I think we've seen a lot of these where you have a small lung and you get this pleural thickening around one side, and then these little kind of subpleural scarring on the small lung. And I think this is a very typical appearance for whatever you want to call it, unilateral hypoplasia, unilateral absence of a pulmonary artery. So this guy was sent to us, but that's not what it was. He was sent to us. I'm not going to show the nuke med study because even though it's a DICOM, it has some embedded PHI. I'll say that there's nothing in the left lung, no flow. So here's the CT, and you can see that there is a PA, or what's left of it, and it's completely occluded. So then the question is, is this CTEPH? And that's what he was sent here for. Thrombus looks a little strange. There's some calcifications which can happen in thrombus, which isn't abnormal. But what's interesting is if you see here, so not only was the right PA completely normal, but if you look here, this calcification here, that's what's left of a pulmonary vein. And additionally, we got some other granulomatous-like calcifications in the AP window region. And if you look at this PA lesion, which is very interesting, it's a very bizarre looking, it's bizarre looking for clot as it is, but let's go down the meat of it. It's very strange, this kind of laminar calcification along the PA. Let me see if I can find this. So here's the left PA, and that's almost like you can see where the calcification, where the vessel should have been. So this wall of calcification, you can even actually see where the left upper lobe branch should have been. It's completely occluded. So, we said, don't bring this guy to UC. And then he has the granulomatous calcifications on the left lung. He has some granulomas in the spleen. So we're like, don't bring this guy for surgery because outcomes are bad if you do an endarterectomy on someone with fibrosing mediastinitis. So here you can see all these really large bronchial artery branches, which is not surprising. And he's had this for a while, I guess. He's a younger guy, but he's probably had this for a good, I don't know, probably a decade, if not more. But this is fibrosing mediastinitis with complete occlusion of a PA, complete occlusion of a pulmonary vein, mimicking CTEPH, and also on the chest X-ray, kind of mimicking unilateral absence of a pulmonary artery. And you can see that kind of that finding we see peripherally with the fibrosis. Question is, is that, I don't know if anyone's ever answered, is it due to the, bronchial artery supply causing the injury, the systemic supply? Is it due to chronic ischemia and causing the fibrosis? Nonetheless, if you do, I'm telling you, I've seen it happen before. Surgeons get very, very angry when they have to, if they go in there for this, and that's what it is, because people die from it if they try to remove that stuff. It's like cement. Another case, if you guys can guess where this is. So
Seth, I've heard the opposite from our surgeons, that they actually really enjoy the surgeries for fibrosing mediastinitis. They say like you go in, scoop it out, and the patients do really well afterwards. They said it's like, often like toothpaste.
for when it's in the PA?
Sorry, not in the PA. I mean, like just fibrosing mediastinus in the lymph nodes, clearing that out. They seem to do well. I don't know particularly what you would do with the PA.
No, they don't like, yeah, they want to do in the PA because there's no vessel to clean out. It's the vessel is just a blind ending pouch at that point. And I've heard actually the opposite from my surgeons, where that's interesting. They say that because a lot of times that conglomerate chunk of scar tissue and calcification forms a mat that surrounds tissues. And that's why it has such a high fatality rate or mortality rate, is because the surgeons can't remove it all. Because it's literally like concrete poured around the vascular structures. That's how one of the surgeons described it to me. So it's interesting that your guy said it was an easy surgery. I've had a bunch of surgeons said they won't even touch it because they've seen too many people die from the surgery trying to remove it. But I don't know. I'm not a surgeon, so I can't vouch for that. So this nail is in the guy's straddling his trachea going into the main stem bronchi. So
Wow.
he's a psych patient, and he decided to start inhaling nails as well as swallowing a lot of stuff, razor blades, nails. So if you ever wanted to see what a nail in the bronchus looks like, or this is a pretty good, see if I can do a quick 3D recon. You can see it sitting right there. It's pretty impressive. I didn't think you could actually inhale a nail. I thought it would just, I don't know, but clearly you can inhale a nail. And supposedly it was, they had to figure out, they tried to get it out with a bronchoscope, but it didn't quite work. So they had to take
It looks like it's wedged in there pretty good.
Yeah, no, it's totally wedged in there. And they had to, they could not get this thing out. So, and then we have a CT belling showing all the, like he perfed his rectum from the, I don't know if he did a rectal, I don't even know what he did with it, but let's just leave it at that. This is a nice case, an older case. And of course, like no matter where you are, this is an outside study, but no matter where you are, it stands true that the site of the most important finding always has some sort of either slab artifact from piecing together two slabs of an axial scan, or some sort of ECG gating artifact, as in this outside case. It really is quite remarkable. But this is a nice case of, you can see part of it here before we get into that artifact, of severe supraaortic stenosis in a patient with, well, not severe, but supraaortic stenosis in a young patient with Williams syndrome. So here's the valve, which is relatively normal, and they get supraaortic stenosis. You can see there's some abnormal soft tissue around the coronaries as well. And then you can see also that the aorta is just basically small. This is like a 12-year-old kid, and this isn't the normal size of an aorta for a 12-year-old, which I think everyone can appreciate. This is a tiny, and you can see all these little gating artifacts. I'm guessing you can always tell how many slices a scanner was done on, but based on the slab difference, right? It should be about 4 centimeters. Yeah, with a little bit of an overlap. So, or at least including the gap. Yeah. So it's a 64 slice scanner. Nonetheless, it's just a nice case of Williams syndrome with you always have to look at the PAs as well. These patients also get PA narrowing, and the PA was a little bit narrow here, but not too bad.
So Seth, I've seen a couple that have been more focal supravalvular stenosis. This one looks like there's more diffuse hypoplasia,
It is,
right?
Yeah, and I've seen, yes, and actually I have cases of both. And I have one kid I showed a long time ago, probably about, I don't know, 7 years ago now, I don't even know, that had it was a newborn that we did a study on, who literally whole aorta was like a millimeter or two. It was just the smallest little thing. But yeah, So it can be both diffuse or focal, and that's true for the PAs as well. And the PAs are usually quite affected, so I'm surprised this one is relatively normalish. And then the last case, which I don't even remember what it is. Let's see here. Oh, yeah, it's a nice case. Just had a PA, one of our young faculty very nicely picked up this abnormal mediastinal contour. And this is just something that, I don't know, don't see as much as I but it's just a nice old pulmonary sling, creating that contour on radiograph. So haven't seen one in a few years, maybe 2 years now is the last time I saw one. So always cute to see the pulmonary sling. And like most people, it's an older patient.
Does he have any airway anomalies?
That's a good question. I didn't read this study, but let me look.
Complete tracheal rings. I mean, given that it's older, probably not. But sometimes you.
She's a
airway definitely looks narrower.
She's a smoke. Yeah, I mean it's definitely compressed in the ring. But when you say airway, so there's right upper lobe.
Well, they either get nothing, or they can get complete tracheal rings, or sometimes get a bridging bronchus, but she doesn't look like she has anomalous lobe, like a bronchial branch.
What's a bridging What's a bridging bronchus?
Does she have two
colitis?
Does she have two hyperarterial bronchi?
Well, I was wondering. I don't know how you. Yes and no, but how does that work with a sling?
The right looks normal.
I mean, here, it's below it, but it
looks more typical.
I mean, it's normal branching.
Yeah.
But it's because of the sling, it's kind of
okay.
Right.
But
a bridging bronchus is usually. David had a case from years ago.
Right.
When you get you almost get like two carinas. So you have a high carina giving off the right upper lobe, and then you have this bronchus that goes down to bifurcate where the normal carina is. Then you have this bronchus that crosses the mediastinum into the right interlobar area.
Yeah, I think the patient we had an upper lobe and then had it was called a bridging bronchus. It supplied both lungs but lower down. So I can show that case next weekend.
Yeah, it's funny. I think I had a case of that recently within the last year, but I had no idea what it was. And it was looked like there was two carinas in the patient. I'll find it. I downloaded it and I just made up some gibberish about something, but not, had never heard of that term, never seen it before. I wonder if that was I'll have to find that case.
Your patient didn't have a pulmonary sling, because my patient was pulmonary sling with bridging bronchus.
No, she hadn't. No, she was actually a cystic fibrosis patient who was undergoing a transplant evaluation, and they were trying to figure out how to do it with that bronchus like that.
I just downloaded your case. I can show it real quickly if you want that. Yours looks like it's mostly normal, which is typical with the adults. They don't have other anomalies, other than maybe some mild narrowing that's asymptomatic. But if you don't mind, Seth, let me show real quickly.
Yeah, I'm done. So,
Seth, you should if there's by any chance complete rings, if there's indentation on the back of the trachea.
I looked. I don't see evidence of that here, but it's.
Okay.
I know if I did you better see that with the CT bronchogram when I do that recon. Let me see but it doesn't look like it. I mean, I could try to recreate that.
Also, if there were complete cartilaginous rings, it shouldn't be so big.
Yeah, it would look tighter, but yeah, I'm done.
Okay.
So
let me just show it real quick.
Grab it.
Move along, but so this is David's case. And there's the sling there, but you can see the lung windows. You've got this funny looking airway. So there's the trachea, and then you see this bifurcation right here at the aortic arch with this small, funny, looks like a carina there. And then this bronchus here continues down the mediastinum. This goes to the right lung. The sling wraps around it, and then it branches again and supplies the lower lobes there.
Yeah, I've never seen anything like that. Yeah.
Here you go, right there.
That's cool.
Yeah, I've never. That's wild. No, I've never seen it. What is that? A bridging bronchus? There's actually a term for that. All right.
Where's my little control thing here? All right, let's try David again. David, were you able to fix your issue?
I think so.
All right.
Restarted. Okay, can people see a person here with situs inversus?
We can, yay.
Okay, and bad bronchiectasis. And this person also had sinusitis and has chronic Pseudomonas infection and some other bugs growing in these lungs chronically. Has nice mosaic attenuation reflecting the small airways component, the bronchiolitis obliterans that accompanies this, and is a transplant candidate. So it's a classic Kartagener. How did I do on the pronunciation, Jeff?
Perfect, thank you.
All right, okay. Among friends, I say, I hate to admit it, but I'll say Kartagener because that's what I learned.
Oh no,
okay,
you can't say that.
Okay, I'll try to be more consistent. This person developed diffuse lung disease. This is a melanoma patient, and it looks like a bunch of fine nodules. Melanoma is one of the tumors that's famous for miliary metastasis. And I don't have an earlier radiograph, but I do have a scout view from CT, fairly ancient, to show that the lungs used to be clear. Now we've got all of this stuff. And here it is on a lung window. Seems to have a ground glass component. There's a ton of lymphadenopathy in here. I don't know whether you can make out maybe small nodules out here. And there's something that's just fuzzing the fissures here. So maybe we have a storm of small nodules, and when nodules are small enough, you can actually get a ground glass abnormality just because you can't resolve the small nodules that are so massed together. So this person has all this lung disease, and I think was a little short of breath. And here it is on CT. So what do you think? Just metastasis or what?
Sarcoid-like reaction.
Indeed, this was sarcoid-like reaction as established on biopsy and aspiration of lymph nodes, as well as lung biopsy. There were granulomas everywhere. And this was a sarcoid-like reaction to the immunotherapy this person was getting with ipilimumab. So this was, you know, a therapy-related sarcoid-like reaction. The person had been on this agent from 2017 through 2019, and then got sick in that later part of that era. So sarcoid-like reaction, and this is not the first case of sarcoid that I've seen that has such small nodules that basically register mostly a ground glass abnormality. So one of the causes of ground glass abnormality is tiny little nodules from sarcoid. 282-2486. Okay. And then this young man, I think in his 20s, has this cystic abnormality in his left lower lobe, these very clean bubbles.
Lucid, yeah.
And it's a left lower lobe abnormality. It's coming up anteriorly, and so you start to wonder, could this be lingula? But I really think what's happening is the lingula, the border with the lingula is just being pushed north there by this extensive cystic abnormality. The rest of the lung is clean. This doesn't look like a post-infectious sort of thing because there's no component of scarring around it. And we decided that this was probably a CPAM, a type 1 with the nice big cysts, which does have a certain rate of degeneration into adenocarcinoma, I think. The type 4 is supposed to go to pulmonary blastoma, and type 1 has the complication of some people getting adenocarcinomas of the lung. So very clean cystic abnormality, classic location, left lower lobe. I think with the combined coronal, we can see that this is below the fissure, so it's lower lobe. And if we look at the SAG, I think we can see that, I think it's pushing the fissure up here, so the lingula is anterior and above this thing, even though this is occupying the part of the thorax that the lingula would normally be in. I think it's just probably lung that's pushing the lingula upward. So a very nice big CPAM. And the guy is currently in the hospital. This case came back from this imaging, I think was from 2012, but the guy's in the hospital because of a perforated duodenum. So we've seen his radiographs again, combined with a lot of acute abnormalities in his chest because of his bad abdominal problems and his surgery. So then I wanted to show you this fellow who had a transplant, not done at our place, back in 2007, and developed chronic renal failure. He has this dialysis catheter in place. And then he had these progressive lung nodules that are mostly in the right upper lobe. And if we look at those on CT, we see that we have a sort of a cauliflower-like ground glass abnormality. I'd like to show you some of the cauliflower aspects of that better down here. To me, this reminds me of cauliflower, these blobs on blobs and the sparing of the lung nodules. You see this sort of pattern with pulmonary hemorrhage, but you also see it with metastatic calcification. And then in the upper parts of the lung in particular, we have the calcification is denser. So there's a range of different densities of these lesions in the lung. Some are just soft tissue density, some are mildly calcified, and some are densely calcified. And this is metastatic calcification. And the pulmonologists tell me that it's usually worse in the upper lobes because of the lung pH varies in different regions. And you know, if you've ever tried to clean your bathtub of calcific deposits, Seth, you live in a hard water area, so you probably have bathtub ring problems, and it's probably a chronic problem for you. So the way you dissolve—
I just thought it was my filth. I'm sorry. That's good.
The way you dissolve bathtub rings is with acid. So you want some acid preparation that will dissolve that. So if you want to precipitate calcium, you want to be in a basic part of the lung. And it turns out that the lung ventilation is better in the upper lungs. And so carbon dioxide is being removed. And the lung bases are more acidic, and the lung apices are more basic. And so the metastatic calcification tends to be in the more basic parts of the lung. It's usually in the upper lungs for that reason. At least that's the after the fact rationalization. That sounds really good to me. So metastatic calcification, and let me show you on here, see the nice distribution of these bigger, denser blobs up here. Okay, those are my cases.
Awesome,
Unmuted.
David. Thank you. All right, Travis, you ready?
Yep.
Which one is you? You're in here twice.
Oh, probably because I left and.
Okay, I found you because your little speaker thingy came up.
Okay. All right. You see a CT. This one.
Yep.
This one is for David mostly. This is back in December. This is a patient. This is just kind of baseline. Patient has a moderate-sized right pleural effusion that's probably just hepatic hydrothorax. They've had a prior liver transplant. Of course, that's part of the important history here. So nothing else really going on. And I keep hitting my Siri button, which is really annoying. Then they go to an outside hospital in February, start to have the dwindles, some fever, night sweats, chills, a little bit of, whatever other symptoms. And you can see there's a bunch of nodules. They tend to be clustered more in the left lower lobe. There are a couple here on the right as well. There's also a small left effusion. Then we can move forward a couple weeks. Now by this point, their effusions have gotten bigger and they've placed pigtail catheters. And this area is kind of coalesced in the superior segment of the left lower lobe. I don't know why that keeps happening with Siri there. And then these nodules continue to get worse. The patient's doing worse. Actually, let me show one more finding. This is another finding that is kind of interesting in this case, is that the upper airway, there's a lot of inflammatory straining in the mediastinum, and the trachea is a little thick, in particular right in here. And we did, a couple weeks later, we did a percutaneous biopsy of this nodule. And I will show you, we also did a simultaneous acquisition just of a conventional CT. And you can see that the airway is still thick a little bit here. And that was actually edematous and inflamed when they did a bronch. And any guess as to what the bug is?
Cryptococcus.
What's that?
Cryptococcus.
Not Cryptococcus. This is
Nocardia.
This is another one that I hear you you speak of in immunocompromised patients on occasion.
Nocardia.
No, this actually is Legionella micdadei,
Okay.
disseminated. I know I've heard you say it before, but this patient had it in their larynx. They had it in their airways. The CT guided FNA grew a Legionella species. Of course, it's a very fastidious organism, and then I think it was PCR from the airway biopsy that ended up growing the specific species. But it's one that, one of the, I guess, a rare Legionella species that will cause disseminated infection in patients who are immunosuppressed from transplants like this.
Well, this is one more way in which it really looks like a fungal infection or nocardia first off. And, the case of micdadei I've seen have usually been bigger pneumonias, but more solitary lesions, not a bunch of, a cluster of little nodules like this. But so just one more manifestation.
Yeah, I pulled up one report where they were talking about some nodules that would grow and then cavitate, and this was originally discovered in Pittsburgh in 1979. So it's also known as Pittsburgh pneumonia at first. But yeah, add this to the collection of rare bugs. All right, I'm gonna skip that one. Now this one is a recent radiograph, and this was a very good pickup by one of my colleagues. And David, I don't know, when you were here, Peter Callan was probably here. I don't know if you worked with him at all since he was in the ultrasound section, but he always is famous for saying that the hardest finding to make on well, he would say on ultrasound, but really on any imaging study is the second finding and the satisfaction of search. And so this is a patient who came into the VA, and he is 100 years old.
He's got a rib lesion on the other side.
Yep, and that's it, right? So that confirms that this is cancer, and right there, that's the finding right there, that you can stage him as at least M1B disease, since he's got at least one bone metastasis. Yeah, and that's the finding right there. And so occasionally, we'll see that when you see something you suspect is a cancer, look for the other lesion. You can see it's in the right middle lobe here, and you might think pneumonia, but then you add the rib lesion in, and you've got your answer. And there is the permeative destructive lesion of that left posterior rib. So we don't have any confirmation on this. I doubt we will get it based on his age, but it certainly looks like a big lung cancer. And he's got tons of tiny little nodules everywhere. So he's got bilateral lung nodules, so that would be M1A, plus he's got at least one bone metastasis, and I think he's also probably got some liver lesions, even though we only got a non-con CT of his chest. So very good observation. I thought it's a nice teaching case for that reason. All right. This is one that's a nice case. This was actually a young patient who had a motor vehicle crash or some sort of accident in the past and ended up getting a thoracic spine MRI at one point. And they made a nice observation of this T2 hyperintense thing in the anterior mediastinum, which prompted this CT. And so it's a fairly large, one of the larger anterior mediastinal cystic lesions I have seen, and this was in 2019. And it really goes all the way from the thoracic inlet, you can see on the cine sequence, all the way down almost to the cardiophrenic angle. On the delayed, on these subtraction images, there's no, or on the delay, there's no enhancement, and there's nothing on, no septations or anything here. So the real question was what's the origin of this benign anterior mediastinal cyst? Is it pericardial? Is it just mesenchymal? Is it thymic? They also underwent CT at that time, not really adding anything, but it does go up pretty high and insinuates between the superior vena cava and the arch vessels. and then down to here. Now, what's interesting is they were just going to watch this because it's benign, but she more recently was coming in with worsening chest pressure, no fever or anything, but you can see over the course of a year and a half that this thing has considerably enlarged. It grew, probably doubled in volume. So they went and took it out. Anybody want to guess what the origin of this is?
Bronchogenic?
I think the clue is right here. So I didn't know if it was just going to be a pericardial or whatever.
Well, did it bleed into it? Because it doesn't look like pericardial shouldn't bleed. Why is it so heterogeneous on the T2?
That's a really good question, and I don't know how much of that is technique on this study. Let's see. It was a little bit more heterogeneous here. Not a ton, but was it because we thought maybe it was super infected or hemorrhagic or something?
Yeah, that's what I was thinking. Bronchogenic
because it enlarged and she had symptoms, but
thymic cyst.
It's a thymic cyst. It was unilocular, and on their description there was no inflammation. The fluid was clear, which is weird. It had just gotten bigger, and so maybe her symptoms were unrelated to that. But on their description, it extended superiorly and turned out to be coming off the inferior aspect of the remnant thymus. So,
Travis, on the CT, you can see it looks like there's some residual thymic tissue that's being pushed to the left by this.
Right there.
If you come down a little farther, I think. Yeah, so like right over here.
All of that, right.
Yeah.
Yeah. So, I mean, it's more of an academic point of interest that this is confirmed of thymic origin.
Travis, does that mass effect on the right atrium also?
I think a little, but it wasn't really. Let me go back to the cines.
I thought the septum was the interventricular septum was flattened.
No, cyst wouldn't do that. They shouldn't.
No.
Yeah, cyst wouldn't do that.
No, but on the second one, it looked different.
Yeah, the follow-up was done more as just a standard thoracic rather than cardiac protocol. No, there's no real mass effect there. So,
okay,
I'll show one more if that's okay, just to finish out the hour.
Sure, and I got one case to share from Vasilios that he's going to talk about. So,
okay, this is a middle-aged patient, and she has a history that I'll discuss in a moment, but the history we got was just follow-up aneurysm on this study. You can see her ascending aorta and her proximal arch are enlarged, but also there's a little bit of thickness to the wall here, and it's a weird enlargement of her aorta because it's somewhat segmental, where there are areas, especially down lower, you have some dilation of the descending aorta, maybe a little bit of wall thickening, and then you've got like weird little segmental areas that are a little bit narrower. So it's kind of got this beaded appearance. And we did have one prior CT to compare to, and I think you can see on the coronal that there's a little bit of wall thickening here too. So certainly with this kind of weird involvement of multiple different areas, that you have to think about some sort of vasculitis. And she actually had a history of giant cell arteritis and not Takayasu. And I think this is like maybe the first case of a confirmed giant cell arteritis that I've seen, or at least what they attribute to giant cell truly involving the ascending aorta or the aorta in general. And I'm curious what you guys think, because I mean, certainly it's in the differential. This is the more recent CT, and you can see there's a little bit more wall thickening to the aorta. They did do an ascending and hemiarch repair, and there were lymphocytes in the explant of her aorta. But typically, Takayasu, we've shown a few cases of IgG4, but I don't know. This is the first one I've seen a confirmed a giant cell.
So Travis, how is it confirmed? Do you have to see giant cells to confirm it, or what?
Well, I should say that. Well, and that's one of my questions, because it wasn't confirmed based on the aorta itself. The aorta here, I've got the report. Let me in the aorta, they found a lymphocytic infiltrate in the media, which they said was consistent with a large vessel vasculitis. And she had a long-standing history of giant cell arteritis. And I'm not sure where that came from because that was done elsewhere. She's been to several different institutions. But so, yeah, that's another question. I mean, could it just be Takayasu because she's in her 50s? You know, and again, I don't know. That's my question for the group. She did have a PET, and you'll see on the PET that this was done around the same time. There is some activity in the wall. And she's had prior PETs where I guess there was more activity before she was put on immunosuppression. But I think regardless of the vasculitis, it is consistent with the vasculitis and that kind of segmental involvement with areas that are normal and then the wall thickening. But David, yeah, I agree with your question. I'm not sure.
Okay.
And I guess, Jeff, that's it for me.
Let me share my screen and Vasileios can present these cases. All right. So here is the patient. Vasileios, are you able to unmute yourself?
Yes.
Okay. So 72-year-old male who had COVID-19, and I hope I have the scans in the right order. So we see peripheral ground glass and sort of a reticular abnormality and sort of an organizing pneumonia type distribution, a little bit of some mild bronchial dilation at that time. So, and then we've talked about this before, I'm sure, that you have to be careful on acute lung injuries of not overcalling traction bronchiectasis, because you can get transient bronchial dilation. And I don't know the time frame between the two scans, I don't remember, but here was the patient later on. And you can see that as it goes away, there is a still residual reticular abnormality, but the airways seem to have returned to a more normal caliber. So in the setting of an acute lung injury, just not to overcall traction bronchiectasis, I fell into this trap a few times earlier in my career. I'd say it looks like it's fibrosing and it doesn't look good, but indeed you can get better. And so was this patient treated with steroids or anything?
Well, first of all, hello. My name is Vasilios Gilas. I hope you hear me okay.
Yes, we hear you.
Can you hear me?
Yes, we can.
Okay. So I'm a respiratory physician. I'm specialized in ILDs. I'm located in Athens, in Greece. Sorry to take your time, but first of all, I would really like to thank Professor Kenny and also the rest of the colleagues. I find this extremely educational, and especially in practices where we don't have thoracic radiologists. It's been of enormous help and insight. So I think that from a clinical perspective, there are two main messages. The first one is that the patient actually was referred to our clinic to be I don't know how to be examined in the context of an interstitial lung disease. During taking the history, we found out that he was COVID positive about 20 days ago. The time lapse between the two CTs are approximately 3 months because he was in excellent clinical condition. We chose not to give anything at all. So the first point is that, as you have said already, that organized pneumonia is maybe the commonest type of reaction. So don't rush to any conclusion. And the second, because there is a great hype about the fibrosing tendency of SARS-CoV-2, I think that we have to be a bit reluctant because recently, for example, in the ERJ, there was published they published a case where the patient developed honeycombing. I don't know if it was actually honeycombing. So you just have to wait sometimes and just don't and just be patient. You know, the saying that sometimes all you have to do is let the nature take control.
Absolutely.
Yeah, yeah. I think it was Voltaire. If you check it out, you know, the actual saying is that the art of medicine consists of amusing the patient, that's us, the physicians, while nature takes its course. So I think we have to keep that in mind.
Absolutely. It's kind of like analogous to us preferring to follow lung nodules, because a lot of times they just go away instead of chasing them with needles and things. Well, thank you for sharing, and we're glad you enjoyed the conference. Yeah, this is a nice example of what, I mean, it looks like it's going to turn into NSIP, and it really doesn't. So, okay, well, it's just past the hour, so we will meet again. And for those who didn't get to present this next week, save them for next week. I'm glad to see a lot of people on. It's great, and I'll talk to everybody later.
Thanks, Jeff.
All right,
Thank
bye.
you.
Thank you very much.